Great. I think we can probably get started. So welcome everyone to the Aging Initiative, Advancing the Science of Multiple Chronic Conditions. This webinar is presented in collaboration with the Aging Initiative, an NIA-funded initiative that bridges the expertise and leadership of two powerhouses for research on multiple chronic conditions, the Healthcare Systems Research Network and the Claude D. Older Americans Independent Centers, or Pepper Centers. The Aging Initiative is led by Dr. Jerry Gurwitz at the University of Massachusetts Chan Medical School, along with co-PIs Elise Adams and Jay Magaziner. There we go. Great, so my name is Anna Quiñones, and I'm a gerontologist and professor in the Department of Family Medicine at Oregon Health and Science University. I co-lead the Aging Initiative's MCCs Research Innovation, Translation, and Dissemination Core, along with Dr. Barrett Bowling, who is an associate professor at Duke University and the director of clinical programs at the Durham VA Geriatric Research Education and Clinical Center. I have the pleasure today of working with my colleague, Dr. David Dorr, on the project that we'll be presenting on, Advancing Person-Centered Care Planning for Persons with Multiple Chronic Conditions. David, would you introduce yourself?
I'd be delighted to. Thanks, Anna. I am a professor of informatics and an internist here also at Oregon Health and Science University. I'm also the Chief Research Information Officer and have long studied models of care for people living with multiple chronic conditions, especially older adults.
Great. So I'll give a brief overview of what today's seminar is going to look like. So I'll give an overview and a background of the project, talk about the specific project objectives and tasks. The tasks that we'll be presenting on are a couple that comprise the entire project. So we'll talk about the technical expert panel that we convened, the environmental scan report, those near final baseline scan findings. Embedded within those, the key informant interviews that we conducted, and then two additional tasks that comprise the project, the partner roundtable learnings and the learning collaborative learnings. We'll round out the presentation with our two discussants, Barbara Kivowitz and Rafael Samper-Ternent. Barbara has been a clinician, consultant, researcher, and author specializing in healthcare innovation and patient family-centered models of care. She's the co-author of Love in the Time of Chronic Illness, a guide for patient caregiver partners and for the clinicians who help them. She's taught at healthcare organizations, medical schools, and at conferences for patient caregiver groups and for clinicians. Barbara's a long-term member of the Aging Initiative's Insights and Perspectives from Patients and Care Partners panel, the IP4, and has been a patient family advisor at Sutter Health for 7 years and participates in state and national patient and family focused health initiatives throughout California Health Compares, the American College of Physicians, the National Institute on Aging, CMS, HRQ, and the CORI. Barbara has graduate degrees from Harvard and Simmons University, speaks 5 languages, worked as a clinical social worker with marginalized groups, headed up an innovation R&D practice at IBM, and consulted with the state of Vermont on their healthcare strategy. So I feel very humbled and honored to have Barbara join us as a consultant. We're also joined by Dr. Rafael Samper-Ternent, who's an associate professor and associate director for the Consortium on Aging at the University of Texas Health in Houston. His research focuses on understanding factors that lead to health disparities among older Hispanics and their family caregivers, especially those with Alzheimer's disease and related dementias. Dr. Samper-Ternent's goal as a clinician scientist is to produce evidence that informs intervention development and implementation to improve the well-being of Hispanic older adults and their family caregivers. For the last decade, Dr. Samper-Ternent has collaborated with clinicians and scientists of different academic institutions across the globe. He's also an alumni of the Aging Initiative's MCC Scholars Program. So we're very happy that they're both able to join us and discuss this project today, and then we'll open it up for questions. So to provide a little bit of background about the project that we're undertaking, I think this will be a surprise to none of us here. People living with multiple chronic conditions, often have to navigate a very complicated and fragmented healthcare system that involves getting care from multiple providers, potentially across multiple healthcare systems, certainly across multiple settings, and manage multiple treatment plans. Fragmented care, which has also been published about extensively, is quite inefficient, it's duplicative, it's costly, it's risky, and it unduly burdens people living with MCC, their families, and their caregivers. And then people living with MCC may also have unmet social needs that further impact their health and well-being and their ability to age well. So with that background, the project objectives are twofold. First is to understand the current state of the field for models and approaches of person-centered care planning for people living with MCC. And that includes innovative and successful approaches, so new approaches as we learn about them, as well as gaps in our knowledge about how to implement those models and approaches. Tied within that is understanding barriers, facilitators, and also the necessary conditions that are reported and that are experiences for persons implementing these models and approaches, as are identified by our multiple partners that have contributed to this project, including policymakers, health system leaders, as well as frontline providers and clinicians, researchers, people living with MCC, and their caregivers. At the end of this project, which culminates at the end of next summer in 2025, we will develop an action plan, weaving together all of the learnings across our multiple activities and tasks. That action plan is anticipated to facilitate the scale and the spread of person-centered care planning for people living with MCC across diverse health systems and settings in the United States. So we are doing this with active engagement from experts, partners, practitioners, implementers, researchers, and importantly, with people with lived experience and their caregivers. We've done this through active engagement, and it's our hope and our expectation that this will provide some foundational knowledge for ARC's larger long-term goal of promoting person-centered care planning as standard practice for people living with MCC. So first of all, we employed ARC's definition of person-centered care planning. So this is a process of active collaboration. It involves shared decision-making that incorporates patients' goals of care and fits into that person's life context and their lived experience. It's characterized by team-based collaboration. It focuses on coordinating the identification, treatment, and management of health for people living with multiple chronic conditions or those at risk of multiple chronic conditions. Patients engage in that collaborative shared decision-making with their clinicians to develop an individualized care plan that aligns with their preferences, their values, and their goals of care. And that care plan should follow the person wherever needed across different providers and systems for that care team coordination element. So if we think about this and map it out, that process of person-centered care planning ought to or aspires to provide high quality, comprehensive, longitudinal person-centered care for people who need it most, people with multiple conditions and multiple issues. And it's a critical challenge that affects health and well-being of those people and their care partners. So how can we think about building better systems to address these needs? And we think about this as spanning throughout the multiple levels, from people living with MCC, engaging with their clinical care teams, and also thinking about their lived contexts and those home resources, community resources around them that should be available and should be connected to them to enable that whole person care and aging well. So I'll give a little bit of a project overview of this ARC contract. We have a pretty compressed timeline. We started in January of this year and will span through the middle of next summer, July of 2025. The project includes 8 tasks, but I'll talk about, along with my colleague David Dorr, we'll talk about 4 of them today. So we'll talk about the technical expert panel that we convened, an environmental scan that we conducted, the partner roundtable that we convened with health system leaders and policymakers, and the learning collaborative, which was a parallel panel that we convened comprised of frontline providers, implementers, and real-world users of these models and approaches of person-centered care. We're joined by a really excellent team across many institutions, many of whom housed here at OHSU, but also across other institutions. Dr. Dorr and I are leading several of these activities, but we're joined by Drs. Annette Totten, Deb Cohen, by Ann King, Serena Schrager, Mary Henningfield, Lindsay Anderson, Amelia DeMarcus, and then multiple others, Melinda Davis, Zolt Nicaldi, and then our excellent project managers, Leanne Michaels, Kate Peak, and technical writers, Jen Corey. So lots of people are contributing to the many, many activities that are involved in this project. So I'll get us started and talk about the technical expert panel. So we convened this panel. I believe we were meant to convene 8 to 12, but we have 18 members, so lots of excitement about engaging with this project and contributing to the long-term goals of this project. So we looked to the TEP to provide input across the life course of the project. So thinking about from the beginning, helping us to identify successful strategies. So those models and approaches, what's new, what's happening, who has experience with what, who do we need to talk to? They help us identify participants and session topics for those 2 parallel groups, the Learning Collaborative and the Partner Roundtable. They will help us develop recommendations and next steps, and they'll assist in disseminating project findings and products. So we've completed 3 meetings with the TEP, and we have our final upcoming meeting, I believe in January, with the TEP. So as I mentioned, we have a full lineup of some really excellent experts in this field. Want to highlight the 2 that will be joining us today in as discussants. Barbara Kivowitz and Rafael Samper-Ternent are sitting on our technical expert panel, but we really have a wide variety of expertise and experience for this topic. So to date, the TEP has given us some great leads and suggestions for new models and approaches to include in our environmental scan. They've helped us by sharing unpublished or maybe some reports or great literature, really giving us those clues and leads of things that we need to follow up on for possible inclusion and discussion in our project findings. That input on draft environmental scan findings, those reports, you really can't get that done without input from the TEP. And as I said, helping us to identify participants and session topics. So these are all important discussions of what's needed to advance the field, and we're really grateful that the TEP has been engaged with us thus far to help us achieve these objectives. So I'll move on to the second task, the environmental scan. This is a little bit more of a meaty presentation, so I'll try to give you an overview of what we've done so far, where we are, and what we're finding. So just really briefly, to set the stage, the purpose of the environmental scan was really to map the landscape, who's doing what, where does there seem to be signal of effectiveness and use and reach of different models and approaches for person-centered care planning. We broke this up for our contract into 2 main pieces, a baseline environmental scan that really talks about where we are, and then 2 rapid scans that we are currently undergoing that we've added on that are topics that came up from our TEP discussions, from our partner roundtable discussions, and our learning collaborative discussions. And these are rapid scans that are intended to complement what we're finding in the baseline scan with these new pressing questions that really should help to round out that topographical map of where we are and where do we need to head next. So those two rapid scans, one is going to be on measures for PCCP implementation, use, quality, and effectiveness. What kinds of metrics and measures are we using to hopefully start tracking accountability, use, and quality of those PCCP models? And then the second one involves addressing social needs as part of that person-centered care plan. So those connections to community resources. As I mentioned, the purpose of the baseline scan is to just describe the current state of the field. So we've identified the innovative and successful approaches and models, and then also try to document the reported barriers and facilitators based on what's been published and also on, again, word of mouth from our experts. The environmental scan will feed in to other project activities and tasks, and notably the summit that will be convened in March of next year. So the baseline scan has been completed. We've identified about 40 or 41 models and approaches. These are all of them listed here that are included in our report. I won't linger too much, but I will just call out the ways in which we are extracting information from the published literature, from the gray literature around these models and approaches. Here's an example. So we try to be as faithful as possible in finding that source publication that describes the model and verbatim grabbing the description of what that model is intended to do, and collect that information into the report. So here are two examples. The impact program is based on goal setting and uses community health workers. The Missouri Quality Initiative in turn uses an advanced practice nurse and focuses on that person to do some early detection and management of residents' conditions. Just two examples from our 40 or 41. So what we did in the baseline report, we abstracted quite a few of the elements that describe that model and approach. We also sought to sort through those different models and approaches based on the description offered by the model authors. So we extracted and abstracted the elements that make that model and approach different from usual care. And based on their description, as a team, we identified what we thought was the essential element, and in some cases, essential elements. Some of the models and approaches looked to have two essential elements. And we looked at it as a team, and we categorized these elements that characterize these models and approaches with these 7 types. So they could involve adding people or changing their roles, implementing innovative models or models for payments or incentives. They could add a novel or existing technology. They could involve the use of decision support tools, the addition of services, the addition and clinical services, for example, like adding physical therapy. They could involve adding functions such as case management or increased case coordination, or it could involve changing an entire focus. So changing the focus to prevention, for example. So these are the categories that we came up with as a team, and then we applied them to those models and approaches that we identified. And then we tabulated them. So we drafted some tables and we organized them. The stars denote the essential element, and we also have a brief description of those elements for each of the models. And the check marks involve the other included elements of that model or approach. So some people love tables. I personally really like figures. So we also use those tables to develop a couple of alluvial plots or Sankey plots. This one's quite busy, but it's really informative. So this involves all 40 models. The yellow lines are the essential elements, and the other colored lines involve all of the other elements for that model, which are all listed here on the left-hand side, and they flow into those 7 categories that we identified as those that characterize or distinguish this model from usual care. So what this tells me is a couple of things. The people and roles essential element, there's a lot of yellow there. It seems to be, it is the highest or kind of most frequently noted new element to that model and approach. But functions is also a very frequently added element, not quite as popular in terms of the essential element, but equally popular in terms of being included in many of the models and approaches. The other thing to note from this diagram and from the tables is that it's really, really rare to have one element for any of these models, right? They're doing multiple things. It's multimodal, it's multi-pronged. They involve multiple moving parts to their approaches. So there are definitely multi-component and multi-level interventions that will be needed. So what we also did to help the reader is we took that Sankey plot that listed all 40 of the models, and we broke them up by the essential elements just to make it a little bit easier to see in isolation with these subplots, these subset plots. Each of a subset plot focused on one essential defining element. So this figure here, figure 2, displays all of the models and approaches that we determined had the essential element be people and roles. Again, just to help disaggregate some of that information and make it a little bit easier to see. So we did that for all of the essential elements in the report. Checking the time. Great. So I'll move on. We also abstracted reported barriers and facilitators, and then grouped these into overarching themes. The reported barriers were reported more frequently than facilitators, but if you notice, the facilitators are almost identically converse to the barriers. So where barriers reported involved, the challenges involved with changing roles and organizational structures, facilitators involve flexibility to manage those team roles and functions. Often cited barriers involved, need for more resources, and then I think really importantly that instilling culture change. And then the 6th one, misalignment with existing policies and programs, were often and frequently reported barriers. And again, the converse, attaining culture change and alignment with policies and practice, were noted in those cases where things worked particularly well. Also want to note, we did make an effort, again, to display, a rough scan and a rough sense of where we see evidence of impact or evidence of effectiveness. Again, this is not a systematic review, it's just a scan. We looked at the last 5 years. It's a really brief snapshot, so we can't say anything definitive as we would in a systematic review around the effectiveness or the quality of that evidence, but we can give a sense of how effective these models seem to be. There is, it seems like it is possible to do this. We have a good or recent, evidence base over decades of trials across very varied approaches of person-centered care planning for people living with multiple chronic conditions, across multiple outcomes that matter to patients and that matter to systems of care. So in more than the majority of studies, the vast majority, we saw better outcomes in the comparison or control. Moving on to the qualitative aspect of the environmental scan report, we also conducted key informant interviews to get a sense of, what people had to share that maybe goes unreported or unpublished, what might be important in their real-world experience of implementing these models or being a recipient of these models. We also interviewed people living with multiple chronic conditions. So we included 13 total interviews in the baseline report, 7 with non-federal key informants and 6 federal key informants. We attempted to maximize variation in informant expertise and talked to people that were involved in designing or using or experiencing those person-centered care planning approaches. The selection of our informants was purposive and iterative, so we also were able to refine the data collection process and the interview guides in the process of that. And just to give you a sense of what we did, we had 2 comprehensive semi-structured interview guides, one for the federal representatives and one for the non-federal. There's some excerpts there on the bottom to give you a sense of the way we mirrored those questions and the probes depending and tailored to the person's area of expertise and their experience. And then I'm going to show you briefly 2 quotes that I thought were fairly compelling, one from a federal key informant and one from a non-federal key informant. So across the interviews that we had with the federal informants, the federal representatives, informants, there were several findings that stood out. So informants had a shared understanding of the benefits of person-centered care planning, including that there are better health outcomes, and then also around the facilitators, such as training clinicians and evidence of improved outcomes and costs. So there seems to be some understanding, some shared understanding there at the policy level, at the federal agency level, of the importance of person-centered care planning. Thought it was important that across our interviews with federal informants, they noted 4 barriers to conducting PCCP besides the lack of time. So lack of time is often reported, but going beyond that and a little bit deeper, one was being equipped with the resources to aid patients during that conversation, really kind of giving people the tools to do this kind of work. The education for direct care workers on what PCCP is. Again, creating that shared understanding of PCCP, the competing demands for pay for performance and the incentives that pay for performance creates, and the challenge in documenting care plans in the medical record for other care team members to use. So a variety of barriers there. And a quote here from a representative from the Administration of Community Living: people don't really truly understand what person-centered care planning is, and I think it's especially from direct care workers. There's just a lot of opportunity for improvement in understanding how to put the person first in their care planning. And then from a person living with MCC as one of the non-federal key informant interviews, couple of things of learnings from those people with lived experience or people with experience in the front lines in implementing these models. No one model is consistently used. There's a variety of models. This tracks with what we're finding in the scan of the literature. However, learning about patient goals and priorities, where patients feel heard, where their context, their lived experience is appreciated, that was consistently used as a way to plan to create those long-term goals. And key informants described the multiple ways in which they were able to do this. Motivational interviewing, narrative medicine, they mentioned one of the models that we identified as well in the environmental scan, the patient priorities care framework, as one among the models that they've adopted and applied in their practice. So the quote that I thought was really resonant, at least for me, a guy in a white coat handed me some paper and said, "Here, you need to sign this." And that's exactly what I did. I signed it and said, "Here, get away from me so I can at least try and enjoy my time in this dialysis chair." It was a task. And the task, we both checked our box, and that was it. It meant nothing to me at the time. It was a nuisance. I had zero input. And I contrast that with the care plan that saved my life, where the piece of paper came last. I'll turn it over to Dave to talk about the partner roundtable.
Thanks. That was a great quote. I really enjoyed it. So our partners in the partner roundtable, I mean, one of the things that I hope people get out of this is like uh, constructing conversations with many different audiences that are interested in this. Um, so in the partner roundtable, we have a variety of people from groups who are interested in policy payment, culture, and evidence generation overall. So payers and other other groups, people focus on policy that really help us understand the broader context and the opportunities for adoption and scaling across many different settings. Go to the next click. Um, and then help us understand the kinds of levers and facilitators that we could identify as part of this action plan for our implementation challenges that have been identified. Go to the next slide or next click. Yeah. So these are our partner roundtable members, and they represent an incredibly wide group, probably the widest set of groups. I bolded people who have lived experience and really or represent those with lived experience. So we do have that representation and sort of italicized people in related areas. And you can see there, oh, if you go back real quick, that they are everything from leads of foundations who are focused in this area to payers to government employees to people in charge of organizations that are focused on disseminating change. If you go to the next slide. So similar to what Anna presented, we really talked to them about barriers, and you can they are coming at this from many different angles, including a lifetime for many of them, and really trying to get person-centered care and whole person care, as we phrased it here, in this in the world. And you can see very similar kind of elements of time and trust and um, the incentives was a key component. If you go to the next slide. Um, so, some of the things that this group explored are really related to how you spread this to groups that might not be seeking care or able to access care, perhaps in a broader context, such as those that are socioeconomically, and really talking through from some experts around this in terms of how you deal with this low engagement, in terms of really not having a usual source of care, really not being asked about their preferences um, overall. So really not feeling understood in terms of what they would seek, and also having really either limited healthcare access, either through insurance type or lack of insurance, or living in resource limited settings. You go to the next slide. So here are facilitators, sort of, again, the flip side of it. But the biggest thing they talked about is sort of uh, the need for leadership, really people with a vision and a will who can build coalitions and really describe this as an urgent need, and then work with others to engage them and build collaboration. And one of the things that is subtle in this is that demand for this kind of care we would think would be universal, but people actually expect this to happen already and are surprised and unhappy when it doesn't. And so really trying to work with families and people living with multiple chronic conditions is crucial, right? To build up that trust overall. We've had a lot of presentations across a number of the models that Anna mentioned, and they've been pretty delightful in terms of the breadth, I'd say, in terms of some of the ideas that came from these are anywhere from a model that's being implemented in different places and the perspectives on that model in terms of diverse settings to whole new ways of paying for care, like money follows the person program, as well as successful, models that combine payment like PACE, what are the opportunities for scaling that? If you go to the next slide. So what we found from these presentations was a really nice set of principles that shouldn't surprise you, I think. So really trying to they focus on what matters, and this is what matters to the person living with multiple chronic conditions and their care partners. Broadly, the relationships, which is important because I think it really talks about the socio-ecological aspect of this, that there's tight relationships. And then as you go out into the broader world, all the way up to those who set policy, how do you help to consistently build relationships across those settings so that people feel seen and heard and feel like they're able to express what matters? And then really this intentional involvement of the family, which is a core focus. So really trying to have programs that or approaches that move beyond here's an individual who comes for a transactional event with us to they are part of this socio-ecological model, and we recognize that their social setting, their family, that support and that capital is really important. If you go to the next slide. Um, so the other thing they identified that I thought was especially good, and we did have some amazing presentations on this that I can't possibly focus, is explain in as much detail as I'd like, is that there are needs across a broad continuum and for adoption and scale. So again, we didn't do a systematic review of these in part because just developing the language to talk about, person-centered care planning, again, something that probably many of you have spent your lifetime on delivering or thinking about. There's a lot of variation in language and in just trying to get that evidence base defined, the definitions defined, and then thinking about this implementation science approach for how you make effective change. There's a lot of research needed. For quality measures, we did hear there's a number of initiatives trying to focus more broadly on relationships and continuity of care and care coordination, shifting from our standard sort of just did this patient receive this, widget of care, or did they, was their intermediate outcome better for a single condition, to a much broader look at goal related issues. For payment and resources, this is a tough one. There's been a number of initiatives and, some successful, some not as much. And so really this idea that we'd scaffold to try and build, work together across different payment mechanisms and ideas, whether it's broad value-based to individual fee-for-service codes. There's a number of levers we could pull. For workforce, there's still a sense that we're not getting enough training broadly in this, and that needs to continue after graduation. And then there's so much in terms of the local context that needs to be adopted. Who's the population you're servicing, what resources are available, what workforce are available, because there are so many different kinds of models. There may be ability to adopt or adapt different models for different settings. Next slide. And then for me, the learning collaborative, which are people trying to implement this in care, who are really, at the front line. And they're, again, focused on models and solutions to known implementation barriers. I feel like this group, we've spent a lot of time trying to find hope again, focus on joy, focus on appreciative inquiry, because it can feel really daunting when you're on the front lines trying to do this day in and day out with the various pressures in the health systems. So we have 40 people, and we will have our final of 5 sessions in January 2025. You go to the next slide. And again, similar presentations, getting their challenges, what goals they'd see, which was an amazing. I'll show you some examples of the kinds of conversations that we've had. Again, trying to give some examples and experiences across settings. I presented on Care Management Plus, which is the model I co-developed with many people 20 years ago. But the patient priorities care and guide model were really, really helpful in sort of giving people ideas about the success. And then we focus on some barriers and challenges where things have been difficult, and then really focused on, how you do this, right? How do you make this kind of change in your organizations? And then we'll sort of summarize that, where get them to tell us where they think there's good implementation strategies that we can coalesce around in areas of future research. If you go to the next slide. These are our members, and I apologize. There's actually more people with lived experience here, not just one. But again, a broad set. If you go to the next slide. So what did we learn so far? One is that this is truly an important motivator for people in terms of really focused on the people that we serve, and working together with them to improve their well-being, sometimes despite what we feel are contradictory requirements overall. And how can we improve those requirements to really drive towards that desire and improve training? We talked about these core components and had some, again, facilitation barriers. Can you go to the next slide? So these are, I don't expect you to read this, but I thought this was a beautiful exercise where we really talked about all these different components, and what the opportunities are. So lots of ideas. And in many ways, this is just a wonderful way to build a positive culture of thinking about ways that we can improve. If you go to the next slide. We then, ask them about the key components for their priorities. And again, this idea to understand what matters most to patients and meeting them there, as well as really dealing with social needs, was felt to be a major issue, although many of these components for PCCP were felt to be important. Next slide. And then similarly for obstacles, as we've heard before, the structure of how we organize our health systems for reimbursement, such as like having very short clinic visits, all sort of rotate around the challenges for payment, as well as a lot around workforce training and retention in terms of adapting to a PCCP approach. Next slide. Then we talked about models, and really talked about these ideas around getting a very clear implementation plan in place, but then expecting that to be adapted, really aligned with the consolidated framework for implementation research, if you're used to that model, in terms of, what are the core components and what it needs to be adapted as part of this. A lot of work on trying to understand culture, understand sort of the energy to change, and helping to try and where teams morale is challenged, shifting culture to be ready for change, and then really engaging in team-based care. What's the next slide? Then when we looked at these other case studies with some successes and challenges, there was a broad discussion about a number of aspects that I think we've talked about, but really trying. A lot of this comes, are our systems working well? Can we overcome cultural gaps like inertia? Can we deal with workforce issues? And then I really like this 5A's framework for really thinking about awareness, assistance, adjustment, alignment, and advocacy at different levels to help facilitate. So you're always thinking about what could I be doing to make change. Next slide. So then the implementation deep dive in terms of planning, implementing, and then contextualizing care. We had a great presentation on that. For planning initiative, we highlighted Cotter's 8 steps. I mentioned 2 of them, which was sort of, building urgency and a coalition as the start, and then making, getting small wins and then moving up from there. So it's a really useful model for change that we've used quite a lot. Oh, if you go back one, sorry. I guess I'm done. Uh, the thing that I really liked, and I highlighted this a little bit, but so one of the things we heard is, people when they do seek care, when they think about getting care, they expect this already. They expect to be heard, listened to, and their values, preferences, and goals incorporated into the care that's delivered. It has different forms, but when they have MCC, often they have some experience with the health system, and they are. What we heard frequently is there's a lot of outrage about that this doesn't happen already, right? And one of the things we've been talking about a lot is really trying to build clear expectations. Like, yes, you might not get this, but you should expect it, right? And how can we help to communicate those expectations uh, across many different settings so that the teams providing healthcare will listen to the needs of the patients and their care partners. And then really a lot about supporting this passion and desire and motivation of our workforce with better training, adding evidence, and then focusing on scaffolding payment reform, really learning from that. There's some great examples out there, and how do we sort of coalesce around that? And that is all we have. So I'll turn it back to Anna for conversation.
Sorry, that was all operator error. I didn't mean to rush you through the end there. But so we have a couple of requests from all of you here. We would love to hear your thoughts. I see that there are quite a few comments and really engaging and kind of provocative discussion points in the comment section. We also have some questions for all of you in terms of what are the most important things that you would like us to know to help make this project successful. So looking forward to the summit, to some of the dissemination pieces, we want to make this project as useful to ARC and as useful to our broader community as possible. Again, that roadmap and thinking about how to affect change and how to keep marching forward. So how can you help advance this project? And ultimately, how could you help advance the spread of appropriate, high quality, person-centered care for people living with MCC? I'm adding our email addresses there. I believe Ollie has put in the chat that these slides will be circulated to all of you, and the recording will be available at a website so that you can access this information and send us your comments, your questions, your thoughts, your engagement, which we are happy to receive. But we also have our 2 discussants to help guide us through some discussion points. So I will also turn it over to Rafael and Barbara.
Anna, who would you like to speak first?
Barbara, why don't you go ahead, please?
Okay. So, along with being a long-term member of the Aging Initiative, IP4, Participating in this person-centered care planning for people with MCCs initiative was one of the most personally meaningful and even joyous experiences of my over 8 years as a patient family partner, bringing my lived experiences into the room. This focus is urgent and addresses a highly complex set of labyrinthian issues. The conversations that took place dove deeply into the elements that truly matter most to adults with MCCs, along with, as you saw, a very thoughtful analysis of the personal and systemic challenges involved. And the more I listened and participated as a patient, I felt hope. And here's why. I've lived with a complex pain condition for 25 years. It knocked me out of life and took 10 years to diagnose and another 3 years for the right treatments to give me a new life. I struggled in that desert of uncoordinated, unaligned, specialty-centered patchwork care for those 10 years, desperately seeking help at a time when I was least able to function. And this is not an uncommon experience for people dealing with one or more complex conditions. I saw dozens of specialists in 4 states. Most were kind but unable to help. One paid attention to my husband. None considered community supports. I kept my own case and treatment history. I found the specialists myself, and I became the manager of my own care. And my tumultuous and lonely experience, this was at the high end of the privilege spectrum. White, English-speaking, urban, great insurance, social drivers of health accounted for, and a healthcare background. Imagine what this journey is like for those who, in addition to carrying serious health conditions, also carry the weight of bias, isolation, and all the associated isms. This initiative diligently examined all the essential structures and components of person-centered care planning. In addition, there are 3 experiential elements I want to emphasize that mattered most to me on my healthcare journey. And I don't think they're going to come as surprises to you. And they were emphasized in this initiative, which was part of what gave me such hope. 1, that I am seen as a person and not a condition, and am a full partner in all matters related to my well-being. 2, that my central person, my husband, and for others it may be an adult child or a friend or a professional or a volunteer, is also recognized as a full partner and is treated as the care and life team member who has the deepest understanding of my state and also exerts the greatest influence. 3, that the healthcare delivery universe recognize that they are experts of diagnosing and treating illness, but that health and well-being live in the community. And for person-centered care planning to help adults with MCCs live the life they want, the healthcare system, they can't do it all. They must connect to the community-based system. And this means not just handoff referrals, but navigation and real partnerships that include sharing resources, helping with funding, and designing research that illuminates how to build durable healthcare to community bridges. For me now, as an older adult with a complex pain condition, along with other health issues, the road is still rough, and I still do most of the driving. I truly hope that this quality of person-centered care planning is realized because it will enable healthcare organizations and the healthcare system to be sustained while creating the pathways that bring hope and possibility to patients, families, and to providers. Thank you. Rafael, I'll turn it over to you.
Thank you, Barbara. That was masterful. It's really hard to follow your steps, and this is where my grandmother was wrong. Ladies should not come first when they're going to start this way. But I'll try to follow in your steps. So patient priorities care is one of the models that Dr. Dorr mentioned, and it changed my life as a clinician scientist. As a Hispanic clinician scientist, I was keenly aware of the barriers that underrepresented older adults and their families face day to day when going to healthcare visits and trying to communicate with healthcare providers. And I did my best trying to provide the best care possible, but there was always something missing. There was always something that the books in internal medicine, pathology, surgery did not have. And that was patient-centered care. So all those years in medical school did not prepare me to discover that what I had been taught to do was not what patients wanted and needed. So when I discovered patient priorities care, it gave me a new path forward. And now as a clinician scientist, I've realized more and more that the more I listen to patients living with multiple chronic conditions, the more I listen to their care partners, and the more I work with colleagues that are passionate about patient-centered care, the more I realize that there's a set of skills that we need to develop that will make a difference. And they're not what we're getting in medical school. They're not what we're getting in other universities. And Barbara beautifully put it, right? It's, as clinicians, we don't understand the scope, the difficulty, the challenges, how difficult it is to navigate a healthcare system in the US. But we keep trying to meet the goals, meet the standards, and use the current measurements to show that we're trying and that we're doing. We recently had a site visit for the patient priorities care visit, and the biggest conclusion was no one has pushed back and said, this is not what we need. The problem is, how do we all come together to make this happen, to make this true, to make this real, and to actually listen to what matters most to patients and guide healthcare based on what matters most to patients and their families. And being part of this over the last, 6 months, maybe it's been more or less, has been a beacon of hope, because I've heard from people with lived experience, I've heard from mentors, from colleagues, from friends, from experts, and we all agree this is what is needed. So now I'm really hopeful that we can bring all of this amazing information together and set a map of where we need to go and how we're going to get there to improve the lives of older adults and of their families, and to bring back the essence of healthcare that a lot of clinicians have lost because they're so entrenched in meeting measurements and getting payment for activities that they've lost the essence of what being a clinician is, which is to improve the quality of life of patients and their families. And I want to echo what Dr. Montori said on the chat. Maybe this is a great opportunity to turn the language around and then really think about, is this patients are not engaged, or is this healthcare systems and clinicians are not doing what they have to do to address what matters most to patients and their families?
Thank you both. What a wonderful way to round things out. I know that there's some hands raised. There's some comments in the chat. Hopefully, Ollie and Kyle, we can capture the comments. I think a couple of the folks in the comments are on our technical expert panel, so we expect you to continue to be engaged, to meet with us in January, to come to the summit and hash a lot of the really provocative questions that you've placed there out with us and help us make this project even more impactful and more beneficial. There are a couple of hands raised. I don't know that we have any time. I was going to take one, but I think we are at the top of the hour. Maybe if, I don't know, any guidance on whether we could take one of the hands raised?
I'm happy to stay on if you'd like to, whoever would like to join.
I think Amanda Schwann had her hand up for a while. Amanda, please. Go ahead and unmute yourself.
Sorry, I didn't mean to have it up. That was my bad.
Okay, no worries. Joanne Lynn, you had your hand up. Did you also not mean to talk? You want to unmute yourself?
I was just curious to make care planning work really well. There have to actually be the services. To what extent are you working on enhancing the community services, the housing, the food, the transportation, the medical care, of course, but there's such a waiting list now with the Older Americans Act having fallen way behind, and most communities not doing, not filling in enough. So many cities have a 6-month waiting list for Meals on Wheels and 6 years for housing. Seems like person-centered care planning is going to need to work on the context in which it's happening and not just accept the shortcomings that you run into. Things just should be there that aren't. What do you think?
Yeah.
Are you seeing that, and are you training for it?
Yeah, it's an excellent point. And I think we focused so much on talking about changing culture and changing the demand, the expectation for this kind of care as standard practice. But we haven't often talked about the supply side issues of what connections there are, the variations between different areas, different geographic locations, and the nuances of how that changes over time, depending on policy factors, depending on funding, depending on resources. I think that is often a challenge that people talk about. How can I help identify these issues and try to be more intentional around the navigation and the connection when it's not necessarily a given that those resources are going to be there when I need them for the people that I'm managing, for the patients that I
guess I'm
have.
saying we have to get beyond navigation and into going to the city council to enhance the supply. Or
Yeah, that's definitely been a part of the partner roundtable. That's a core focus. But that demand is just the right thing. You're exactly right. Like advocacy and demand and getting broader than health systems alone, or having health systems consider the broader community and social needs, which was actually the second most common thing that people talked about from the health system group. So that's very useful feedback.
I just want to add, I so appreciate that question, that comment. You're so right. And I just read a wonderful article in the Commonwealth Fund, Paying Providers to Address Health-Related Social Needs, Lessons from Massachusetts and Minnesota. And it was all about finding ways to get state funding and Medicare and Medicaid funding to pay providers to address social needs. Fascinating article.
Thank you for the comments, and please keep them coming. We have our email addresses there. Ollie and Kyle, as excellent project coordinators for the Aging Initiative, will circulate this recording of the presentation to have that at your fingertips. And please send along questions, comments. We're happy to receive them and happy to have that help bolster our work. So thanks everyone for joining us, and have a nice rest of your day.